role or the other to improve every single one of these three factors. And then I want you to look at this particular graph. It's from, I think, over 10 years ago. It's quite interesting, though, because it shows something that points us in the right direction. If you look at it, you'll see that around the world then, you had over 11 million hospital beds. And then there were 305 million computers, but over 2 billion mobile phones to serve the world population. So if there's any of these tools that could provide accessibility and universal healthcare coverage, definitely to be the mobile phone. So that's why we are talking about the mobile phone right now. And then this is also quite interesting. Of all the technology that we have had over the years, how many of them have been able to reach, how long did it take for them to reach 50 million users? And then you find out the airline took, the aeroplanes took 68 years to fly 50 million users. Our automobiles, the cars used 62 years to reach 50 million users. The telephone took 50 years. And then the television took 22 years. Our computers took 14 years. And then the cell phone took 12 years. And then from the age of the cell phone, it went ballistic. And everything began to build on what the cell phone was able to do. The internet took 7 years. YouTube took 4 years. Facebook took 3 years. Twitter took 2 years to reach 50 million users. And very recently, a game played on mobile phones called Pokemon Go took 19 days to reach 50 million users. It tells us the power that the mobile has, particularly if we channel it right. And this leads me to talk about a new way to look at mobiles and games called gamification. How mobile can also help to, children these days love games, and people have been able to use these games that they love to play to generate compelling behaviors to make children do particular things, whether it is exercising, whether it is eating their vegetables, whether it is living a particular healthy lifestyle. Gamification has also been used, and it's now getting into the limelight gradually. So it also been known to help to improve depressive symptoms and increase physical activities. So all of that is predicated upon the use of mobile phones, mHealth. And it is the reason why the WHO has, predicated the WHO guideline of 2019 on mHealth as a lowest common denominator. And if you look at this graph, you will see then that if you have a target population that you want to reach with healthcare, you're going to lose some of them to accountability coverage. You may not be able to target all the population with your healthcare system. You may not be able to get all of them to register, but you have the accountability coverage of the target population. And then there is the accessibility coverage. It's not going to be accessible to everybody that wants, and you may not have the available human resources. We know about the brain drain that is a significant factor in our country as we speak with healthcare providers and living the shores of the country. And you also have the inventory to run the healthcare system. This also creates further gaps. And there are technologies that can help you to manage inventory so that you can stock out the OS syndrome. And then you have the demand side, you have the continuous coverage, and then the contact coverage. And then the quality of the coverage. How effective is the coverage that you have? These days you have mHealth apps and digital solutions that can help you to continue to track behaviors and even do what we call behavioral change communication. That can continue to improve on the quality of the care that is being delivered. And then you have the affordability, the financial coverage. So how much of the people that are engaged in the health system are actually able to afford what they are required to the services that they are required to get. And remember that this is one of the factors that we talked about in universal healthcare coverage. Digital health can also help here to make access better and cheaper. And so the digital health cannot be done away with when we talk about universal healthcare coverage. And here I list some of the some points and some of the uses that mHealth help us in achieving digital health coverage, some of the problems that they can solve. One is client education and behavior change communication. We can use mHealth and other digital health solutions to solve that through short messaging, interactive voice responses, video clips, images, and so on and so forth. You also have the sensors and point of care diagnostics. You have registry and vital event tracking, such as pregnancy, antenatal care, remote monitoring. You can monitor pregnant women at home, remind them of their clinic appointments, help them to track and communicate with them expectations at the different levels of their pregnancy, and therefore encourage them to live a more healthy lifestyle. And you have data collection and reporting systems that help to, when you have data, then you have better planning and better policies. Then there's the electronic health records using mobile with GPRS, and then electronic decision support. If you don't have adequate specialist health care, you should be able to support those that you have with electronic decision support so that they continue to perform and bridge the gap of skilled manpower. Then you have the provider-to-provider communication that helps to support even the providers and ensure that they are the top of the best practices for their services they deliver. Then you have provider work planning and scheduling. You have provider training and education. You have human resource management, which is also critical. You can get the required resources to the appropriate place at the appropriate time. Then you have supply chain management through web-based dashboards and then financial transactions and incentives. And we've seen some of the work that M-Pesa has done in Kenya and how it has significantly helped to manage to boost the financial transactions, particularly in regards to healthcare delivery in that part of the world. So mHealth minimum expectations in lower and medium income countries, debt notifications, birth notifications, stock notification, clients, basically some of the things that we have spoken about earlier on. Now, what are some of the principles for implementing mHealth applications? And we have one of them being to avoid a one-size-fits-all. You have to understand the client where the solution is being deployed and be able to tailor-make it for them to suit the particular needs at hand. And there's a need to maintain flexibility. Information will change, and if you do proper monitoring and evaluation, you'll be able to become flexible and adjust as you go along the way. And you take standards and interoperability into account. One of the things that happen with all of the pilots that happen is that none of them see themselves. None of them are interacting very well. I'm glad that Professor Omokwa said that on Friday we're going to have the director from NHIS talk to us about interoperability. It's a very critical part of using digital health for universal healthcare coverage. Then you have evaluating existing information system, track key success indicators for monitoring and evaluation, ensure quality and content of health information, respect privacy and confidentiality, enable public-private partnerships, and you need to map the supply chain so that you know who are the people involved and ensure that you work hand in hand with all partners. And offer training and take literacy into account and ensure commitment of leaders. Now, so after saying all of this all said and done, you need to understand and engage the various stakeholders in the ecosystem. Because one of the key reasons why solutions we have not been able to scale much significantly in recent times is the fact that many of the works is done in silos. We have not brought all the stakeholders, we have not mapped the supply chain, and therefore our work is fragmented and therefore scalable. But we need to understand what key roles different people play in implementation and bring them on board. For the government, we're expecting legislation, the regulators, legal systems, ministries, and then for the technology aspect of it, you know that our infrastructure is going to come from there, software, developers, mobile operators, and the likes. And then you have the financing. We talked about the health insurance. We talked about private sectors. even have philanthropists and donors and development partners that we can all bring on board. And then we map what are the expectations of each partner, and then we work together to build something that is scalable and can solve problems. And then we need to also create an enabling environment. There are several components of e-health that we need to pay attention to. Workforce, particularly, we need to do a lot of training for our workforce. We need to ensure, recently we started making proper headway with regards to standards and interoperability. In 2019, 32 standards were approved for health informatics, and those are some positive steps that we are taking. But we now need to come together and begin to gradually implement some of these things. And then finally, well, not finally, so I said we need to develop an enabling environment that allows digital health to thrive. And that's by ensuring that our ICT environment continues to grow, and then we continue to grow in the area of our governance, policy, legislation, standards, and particularly human resource development. And then finally, one World Bank research demonstrated that part of the reason why mHealth and other digital health solutions are not, being scaled is because that they are not adequate compelling value proposition that can drive uptake. And then for the supply chain, the business model is not clear. Many of the people that could get involved are not even aware. They cannot even figure out how they're going to generate their own revenue, because for the most part, health appears to still stay in the space of being a social venture. So when people are not willing to invest so much into it, where investments are, it's not clear how the return on investment is going to come out. And so we need to work on this area and ensure that there's a sustainable business model that will drive the development of digital health in our client. And then finally, we need to work on research and evaluation. We need to ensure that whatever is being done, we are learning something from it. We are collecting data, we're evaluating the data, and we're iterating as we go along the way. On this note, I'll just say thank you, and then we'll move on to the next phase of the symposium. Thank you very much, Prof.
All right, thank you very much, Dr. Arobundade. That was quite brilliant and robust one. It shows how global your e-health is, and also helps us to realize how far we still need to go. I most appreciate you for taking. I'm particularly interested in the issues you raised about density, coverage, telecoverage as different from, or as a factor for healthcare coverage. Again, I'm happy that you raised other issues that goes with operability of these, of our telephone lines. And that's a very, very major issue. Saying that we have telephones is just a matter of quantity. How functional these telephones and the lines are is a matter of quality. And those are things we need to build into our thinking and into the way we compare data. Thank you very much for taking us into the nitty-gritty. I'm also very, very conscious of your description of another dimension of quality, in which you engage us in the issues of whether the healthcare needs of persons and communities are available. So it's one thing for a healthcare facility to be close to me, or for me to live near a healthcare facility. It's a different matter whether that healthcare facility can provide my healthcare needs. That's very important. That's another dimension of careful study we need to do. So whereas I've been a teaching hospital, it's just possible that the nearest teaching hospital that can take care of my special healthcare needs is hundreds of kilometers away. Thank you. That means I will still need telemedicine. That's the point being brought up there. Thank you very much for those brilliant lessons, sir. That's what it takes to be president. Mr. President, thank you. So we're going into the panel discussion right now. Oh, beautiful family, great. There's a tele distance there between your height and the height of others. All right, thank you. Yes. On our panel, we had scheduled, in addition to Dr. Arogundade, Ms. Tominayo Akinsiko, and Dr. Godson Eze. Unfortunately, moments ago, we got information that Dr. Eze reached me that he will be unable to join us because an emergency came up. There was a meeting he was hoping he would be able to reschedule to be able to join us, but it just didn't work out. He's not in Nigeria. He's the head of the control program for HIV/AIDS in the country of Trinidad and Tobago. And he has been very, very actively engaged in working with me towards this conference. So I know his heart is here as we speak. But that apart, we also have here a very erudite and knowledgeable nurse. She is with us and eagerly waiting to get into the active conversation. She's a registered nurse and has a first degree in nursing. She holds a master's degree, MSc, in public health. Both of these degrees were obtained in the UK. She is a nurse and a public health expert by summary, but she has additional certifications in representing, processing, and presenting data, and also in health informatics for innovation, value, and enrichment. She is a specialist screening practitioner and works with the Oxford University Hospitals, NHS Foundation Trust, England. One of her duties is accurate data entry into local and national databases, something that brings her in close intimacy with the practice of health informatics. She is a member of Shuri Network. It's a gender-based network of women who are involved in digital health. She is also a member of the International Society for Telemedicine and E-Health. So you see, we have the uncommon privilege to bring in a very, very experienced and very knowledgeable and worthy member into this panel, all the way from the United Kingdom. We're happy to have you join us in Nigeria and to join Africa. Thank you very much and welcome once again.
Thank you very much, sir. Thank you for having me.
Yeah.
Yes,
so to start off, Toby, if you were the one giving this lecture from your knowledge of Nigeria, what would be your big blow, that big point you want to bring in from your experience in Nigeria before you left for the UK some years ago?
All right, thank you very much, sir. I think from my own point of view, I think I completed my nursing degree in Nigeria, and I had a couple of experience working in Benin City and in Akure, Ondo State. So I think what will be very important to see the growth of health informatics and e-health in Nigeria, it's actively engaging nurses, and I think in that I think it will work really well in the sense that the 90% of contacts between the patients and health professionals are contact with nurses. Nurses will probably be the first person a patient will see, or probably the last person they will see. So I think in order to promote this agenda, is e-health and gender and health informatics, I think one group of people that we should carry along and to engage them and to pick their brain on what they think on how this, and pick their brain is to engage nurses as well. I know that there's this aspect. One of the speakers was saying something about changing of behaviors. I know some of my colleagues up to now at work still say to me, "Oh, I'm not an IT nurse. I'm employed to look after my patients. I just want to look after my patient and go home." But if we have to embrace this culture, if we have to see the growth of e-health, health informatics in Nigeria, we have to, I think the group of people we have to target our teaching, engaging them and encourage them as nurses. And I think they have a key role to play in this. Yeah.
That's great. That shows that we are truly transitioning, and it's not just something limited to Nigeria. It's a global thing. Not many people really realize that, whereas ICT has been around for a while, but the big electronic transformation took place, let's say, within the past 2 decades or so ago. It has not been a big leap for the world, but again, people have transited to different extents, so we still have a long way to go. But what is of particular interest to us in Nigeria, and for the purpose of this panel discussion, is the issue of coverage, universal coverage. In Dr. Arogunlade's presentation, he looked at coverage from different perspectives. Coverage in terms of the people, he called that quantity. Coverage in terms of the types of services. I hope I got him right. He looked at that in terms of quality and so on and so forth. So where do we stand in Nigeria compared to where you think we are capable of being within a short time? Sorry, I'm back to you again, Tommy. Where do you think we ought to have been by now in terms of coverage using e-health compared to where we are now, based on your knowledge of, your recent knowledge of Nigeria?
Thank you, sir. I think we are in Nigeria. We're probably in the introduction phase, I would think. When Mr. Eze was talking earlier on, he talked about not falling into the temptation of replicating what the developed countries are doing in developing countries. That we should probably look at what works for the system, what works for maybe what would work very well in Nigeria, considering the challenges we have, like internet challenges and all that. We should look at what we have to be able to create what can be specific, what can be efficient and specific to a need in Nigeria. So I think what we are now, and I think going forward, what we'll be looking at is, what we should be looking at is working with what we have, where we are, and making do with available, what we have within our reach. So I think that is the starting point, is to just making do with where we are, starting from where we are, and making use of what we have at the moment to achieve what we can to get a result that is specific to our need in Nigeria. So I listened earlier on about to when the speakers in the first and second symposium, and it occurs to me that there's a lot of initiatives that have started in the past, but couldn't be monitored, and it wasn't a system that lasted for a long time. So that's why I'm of the opinion that it might not be one jacket that fits all situation. It might just be working with the little we have. The little couple of research find out that an average person spend about 3 hours on their phone, checking their phone and be on the internet and all the social media. I think, just as Professor Rogundade said, that's a big, huge opportunity and a gap there. And I think the group of people that are converted already are the nursing students in schools, are the medical students in schools. So if this knowledge of health informatics and health is transferred to them at this very, very when you're in school, because they already know what's all about anyway, I think that's a good start as well. And then because they are in their foundation already and they are converted already, so they will be in the best place to take that forward, work with what we have, where we are to achieve what is specific to our need. Yeah.
Very much. We shall be looking at road mapping tomorrow. And I see what you're saying as linking us up to that. We need to roadmap from where we are to where we ought to be. We don't have to do it the way other countries do it. We just need to give attention to our own unique environment, our unique needs, and our unique resources. Thank you very much. Still on you, I will soon get back to Dr. Arogundade. We noticed that in your resume, you talked about having to handle data, do data entry. You have to do it accurately. You're particular about accuracy. You also have applied health informatics, which you studied in one way or the other. How has your knowledge of e-health helped you in carrying out these duties? And what difference has it made as a nurse to you in your everyday practice?
I think without health informatics and e-health, I would really, really struggle in my current job. And there's no way I'll be able to do my job without health informatics. So what I do at the moment is that patient get referred to me, and with patient's unique ID, I have to look for them on a database, and then I follow up the patient. So I work on the National Bowel Cancer Screening Program, and what I do is invite the population to come. People who are interested in the screening program get registered into the program. So I invite them, I see them in clinic, and I have to put their data on the system. I have to input their pre-assessment information, intra-assessment, and also post follow-up cases. I have to put all of that information on the system. So I don't necessarily deal with paper to record patient details on paper, because it's just, I think it makes a whole lot of sense, because when I record it on the system, 10 years to this time, or 12 years, in 12 years time, people can always check on the system and see what I've done, what service I provided for the patients, and all the information is on there. So without health informatics, I would not be able to do my job. I use the electronic patient record. I have to interact regularly with that. And in pre-COVID, I saw patients in clinic. I'd see face-to-face clinic, and that's pre-COVID. But during COVID pandemic, we had to modify that a little bit. So in addition to that, we went on to telehealth, and I had to saw patients in codes from my convenience of my home, in my flats, because we couldn't see patients face to face. So I had to ring off patients, do my telephone assessment, and it was still the same, and it was efficient in that sense. And I would not be able to do my job without that. And initially, I kind of struggled with it initially because it was a bit different from what I'm used to. So I had to change my behavior in that sense, and able to learn because the system are quite tricky. You have to like get your head around it and how the system works and how to what data you have to extract, what you have to impute. And sometimes if you make a mistake, you can just make everything go wrong. So I had to like learn and to change my behavior around health. And at the moment, I am fascinated about it. And that's what led me into doing extra learning and getting more skills in health informatics and health. So I think going forward is one area I'm fascinated about. And I love my job, and I love what e-health can offer and what health informatics can offer. Yeah.
Thank you very, very much indeed. I was talking with someone recently, and I said, nurses are the main drivers of e-health in healthcare facilities, and that's how it ought to be. And the reason is simple. They handle a lot of data, they collect data, they monitor patient care, all the temperature, blood pressure, respiration, and examinations they do from time to time are captured electronically. Doctors do also. Like we all know, nurses spend more time with patients than any other healthcare professional. So they are actively involved in the use of e-health. And I'm happy that Tomilayo has shared her experience with us in that regard. I want to encourage us all to please begin to send in questions and answers and comments and all that so that we can engage. Yeah, so we are waiting for your questions, for your comments, your answers. But before we go into the charts and Q&As, I'd like to ask Dr. Arogundade, where do you think we are right now in Nigeria? If you were to draw a map of our progress, where are we now? And do you think we're in a position where we can genuinely take advantage of e-health to achieve universal health coverage?
Thank you very much, sir. Where we are right now, I definitely know we are not where we want to be, but I know we are also not where we used to be. I also know that nobody gets it right the first time. We are required to continue to iteratively develop and improve ourselves. Even when it appears that they are getting it right now, I know that things change. We talk about best practices with monitoring and evaluation. Things are changing every day. So where we are right now, I should say this, that in the last 2 years, from 2019, and then we were just interjected by the pandemic. We made more progress in 2019 than we made in the previous 10 years. I think I'm bold to say that because not only were a few things coming into place, the awareness of what has been happening in digital health also took front place. I'm sure you can testify to the level of awareness that has also grown at the UBTH and the University of Benin as an organization and at the state level generally. Many things will not have happened. But right now we have many states talking about policies. I remember as far back as 2012, we're part of a team that developed the first draft document for e-health strategy for the FCT. And it shows that people were already getting, they already knew where they wanted to go. I talked about Lagos State as far back as 2007, piloting an EHR program. Now, what has not happened is that we made some progress, then we find ourselves taking one or two steps backwards. But then sometimes you find that we also try to pick up the pace again. But I can tell that at the federal level, particularly in 2019, there was quite a lot of pace. I remember being in quite a number of meetings at the Federal Ministry of Health, the technical working group there, all working hard to see e-health get to become mainstream. And a lot of progress was made. So I think we are on the right track. If we can pick up from where we are before the pandemic interjected us, if we continue with that momentum we had in 2019, and I also hear that it's beginning to build up at the Federal Ministry of Health level presently, I think we're going to do well. Just a couple of weeks ago, I'm not sure if you were aware, a bill showed up at the House of Assembly. The House of Rep had a bill, and they had a public hearing about the bill. The society made some submissions, and most of the stakeholders in the industry also made submissions towards that bill. It shows that, in time past, some of those kind of bills will just fly by. Nobody will be aware that there was even a public hearing. We are beginning to get that at that level, and it shows that we are making progress. I'm not saying that we are where we want to be. I'm not saying that we are doing perfectly well. What I'm saying is that if I look relatively at what happened some 10, 15, 8 years ago, and I look at what has happened in the last 2 years, I think I'm a bit encouraged to say we are making small steps progress. Over to you, sir.
Thank you very much. I'm happy that you went far into that. The federal government, which you mentioned, yes, has done a lot along with state government supporting, but there are recent developments that bring a bit of a hitch into the process of further development of telecoverage in Nigeria. For a while now, there has been suspension, as it were, placed on enrollment of new users into our tele platforms. What comments you have about that, and what effect or impact might it have on e-health?
Well, talking about that, it has a significant negative impact. But I'm not going to try and second guess or try to judge the reasons behind what they are doing. I'm not going to say I fully understand the rationale, but I also know that in the evolution and development of digital health for universal coverage, there are a few things that are basic. One of them is being able to identify people. We talk about unique identification numbers. I understand the NIN is supposed to create something like that. You can't have universal health coverage if you cannot account for all the people that we are trying to cover. We talked about the accountability, the gap created from the accountability when you don't have a target area. Now, to be able to achieve that, you need to be able to account for all the people that are within your purview. And I think that is long overdue. I also think that we've had quite a lot of opportunities to collect some of this data and to integrate them. Brings us back to the issue of interoperability. A few years back, we were talking about BVN, and we were just barely out of that when NIN came in. Now, all of that data that is being collected over time, we talked about everybody that drives there has a driver's license. We had a voter's card. We had voters' cards. We had all of these places we go to register. We have mobile phones. But we collect a lot of data that they don't speak to themselves. And so there's a need to start connecting the data to be able to accomplish more. And if the NIN helps to accomplish that, I think it's fair, but I think we could do it better. Right now, the fact that we have halted all of that registration is hurting a lot of progress that we were making before. But nonetheless, I still think that if the NIN has a chance of helping us to integrate, it has a chance in helping us integrate the data that we have been collecting over the years, I think it's fair. Only we should do it in a better way that allows for other things to happen along the line. Those are my thoughts, sir.
Thank you very much. I think that gives insights into some of the way policies tend to interrupt or interfere with the potentials to make progress in universal health coverage. It may not have been intended, but that's exactly what is happening, and it's taking too long to address. We need to set up systems that will improve interoperability so that there's no interruption in our progress towards good success. So thank you very much, Dr. Arogundade. Let's see. Well, we have a few comments coming in here. Much of what I see, statements of appreciation to, very well-deserved statements of appreciation to Dr. Arogundade. Insightful presentation, thank you, thank you. Are there questions? There are questions, would like to admit them. Dr. Arogundade, remember, is our president in the world of telemedicine and e-health in Nigeria. So if there are questions to ask him about what he's doing, feel free. Okay, so one more thing. Tomilayo Akinsiku, our very dear nurse, you did indicate when you were speaking a while ago how central e-health has been to your everyday practice. And you are very passionate about it. And really, I connect very well with that. I'm conscious of the fact that nurses have a very tremendous role to play in healthcare. In your opinion, how can nurses promote the e-health agenda?
Very much, sir. Like I mentioned earlier on, you did also mention earlier on, sir, about the huge role that nurses play in healthcare generally. I think because we are nurses generally, they might probably the first person the patients will see, and probably be the last person, first person they see in the hospital, or probably the last person they'll see. So I think if we can not just I know in central to all of it, there's so many facets to making e-health work in Nigeria. We have policy, we have funding, we have setting up infrastructure and all that. But I think central to all of that, what I think is also important is intentionally engaging nurses as well. So when they feel engaged, when they feel that they are part of the team, when they feel that they are part of their suggestions or their ideas, they are being held, their suggestions and ideas are being considered, I think it will go a long way. And when that aspect is sorted, they are in the right position to carry on the gospel of, if I can use that word, the gospel of health to the patients, because they are the closest to them. And I know the aspect of changing behaviors of nurses is still there, but when we've got the converted health informatics nurses, they will play a very, very big role in carrying on that message to the patients. And they'll be in that role to teach the patients and to guide the patient through the e-health or health informatics pathway. So yeah, I think they have a very huge role to play. And one thing that very important is engaging nurses intentionally, because from the setting up, for example, in EPR, electronic patient record, from health assessment, from patient care plans to admitting and discharging patients, a nurse input on how that works practically is very important in setting up any system. So I was I just completed a 4-week course on nursing informatics online, and one reoccurring conversation during that online lecture is that some nurses feel that the system that are designed, because it doesn't involve them when it's brought into the hospital, they struggle to use it only because they were not probably involved in setting it up in the first place. And because of that fact, so they struggle to use it because they were not involved, they were not engaged, they were not carried along in setting it up in the first place. So I think they have a very big role to play. And what is important that would make this gospel go far, the gospel of health informatics go far, is engaging nurses intentionally, and just to engaging nurses intentionally. Yeah, that's what I think, sir.
Thank you very much indeed. That's great. We do have great prospects, and there are big opportunities ahead. Okay, back to Dr. Ade Arogundade. Please, from your experience in Lagos State, I know you're doing quite a bit of work there in the Accident and Emergency Center, which you had. For sure, you're participating in the COVID-19 control. I'm aware of your active engagement there. From what you're experiencing and from what you're doing, can you please share with us what role e-health is playing, e-health and health informatics are playing in the control of COVID-19, either at your center or in Lagos State?
All right, sir, thank you very much. If there's any silver lining for the pandemic, it's that it reopened and reawakened us all to the place of digital health in bridging the gap. In Lagos State particularly, one of the problems we had in Lagos, if you remember, Lagos has been one of the big epicenters of the pandemic in Nigeria. In the early part of the outbreak, one of the things we had was patients became scared of going to the hospitals. Sometime about this time last year, everybody was worried about how if they go to the hospital, they may contact the virus. And then there was also the place of conspiracy theories were flouting all kinds of false narratives of how if you go to your hospital and then you just test you and declare that you are COVID positive. But one of the things that Lagos State government was able to implement at that point was what we call the co-telemed. And through the LASHMAN, as the Lagos State Health Management Authority, a telemedicine setup was immediately launched to allow people to call into hospitals and then make their complaints. And then some of the less serious complaints could be addressed. And if you had a more serious issue, one way or the other, you could also arrange for that to be seen in a way that is orderly and does not put both the care consumer and the caregiver into any unnecessary risk. So a lot of that was happening. And you should also remember that when we talk about telemedicine and digital health, you also use digital health for change management, for behavior change communication. So a lot of the information was being passed to both healthcare workers and consumers in the state. A lot of training was also being done through virtual means using digital technology. That's training the care providers and disabusing their minds about different aspects of attending to the patient. For example, I remember clearly I attended so many virtual trainings organized by the Lagos State government, and I also give quite a number of them, for healthcare workers, for people that were at the forefront. Now, all of that happened, and it's interesting to note that even in the middle of all of this was where some of our hospitals in Lagos State began to launch their own, they launched quite a number of telemedicine projects and EHR projects. As we speak today, the oldest government hospital in Lagos State, General Hospital Lagos, is now fully digitized. They are 100% paperless as we speak. And all began just about last year when the pandemic hit. They've been able to mobilize all their patients into a digital format. So when you come to the hospital, you come in with what looks like an ATM card, and all your record is there, and then you give it to your care providers, and they're able to attend to you paperless. And as we speak, we are working on the modality to try and look at do a study that looks at how that has improved patient stay in the hospital. But suffice it to say that it's made a lot of difference in how patients are seen. And then almost coincidentally, in January last year, 2020, just before the COVID thing hit Nigeria, Lagos State launched the Lagos State Smart Health Initiative program called the Lagos SHIP. And it's supposed to help to digitize the delivery of healthcare in the states by allowing patients to be able to reach, schedule appointments so that you reduce how many patients arrive at a particular location at a particular time. Do a lot of those kind of things. So the pandemic has really opened the eyes of many people, particularly the government. I said that there have been pilots before. A lot of those were looked at and new solutions were evolved and are still evolving. And a lot of things has been done in Lagos State, and they are still doing a lot. So yes, in the hospital where I work, because we're an emergency room and we're not dealing particularly with COVID, or we're seeing patients, we're not managing them as, we see them and we send them to the appropriate place. But digital health helped us to identify, where the patient needs to go and, call for, we talked about decision support. It also provided a lot of that for us. So it's been amazing what we have been able to do in 1 year. And the beautiful part is that it has sparked a movement, and that movement continues to gain speed and momentum as we go forward.
All right, thank you very much, Dr. Arogunlade. It's always a delight listening to what happens in Lagos State. It's called the Center of Excellence. It's even all the more delightful hearing that from the president himself. It does mean that there is hope for Lagos State and for Nigeria, using Lagos State as a direction or as an example many states can follow, and using other countries that have done well to guide our thinking, our planning, our road mapping. Then we have the opportunity to do well. We would not want to repeat the mistakes of poorly designed technology, inappropriate technology, or unaffordable deployment of e-health just because we want to achieve universality. Universal coverage itself means that there should be indeed real coverage. If money that's spent for health services are diverted into other things, then that's not helping matters at all. That brings me to the issue of intersectoral involvement in e-health, which is the very seat or heart of MEHID, mainstreaming e-health, right, for development in Africa. So back to you, Dr. Arogunlade. We have mentioned somewhere along the line the Federal Ministry of Science and Technology. We have also talked about the Ministry of Education. We've talked about the Ministry of Health, among other agencies and private organizations. I want you to please see yourself as if you're the one taking the decision or driving the process. Given our current state of e-technology or ICT technology in Nigeria, how appropriate, how locally relevant do you think our development of ICT can be in order to support e-health?
Okay, so the common mistake that was being made in the past was to approach digital health solution from the perspective of technology. And if you do that, what you have is that technology vendors will push to you all kinds of solutions, whether it addresses the issues that you want to solve or whether it meets your objectives as a whole. And we've had a lot of that in the past. And I'm not going to say that some of that is still not going on. I believe it is still going on, particularly considering some recent events. But the perspective is beginning to change for many stakeholders. And they are beginning to see that we need to start from the perspective of our objectives. What are our healthcare objectives? What are the problems that we want to solve? And then what minimum level of technology or solutions that is sustainable can we point in the direction of that problem? And then we can go from there. We can go from, oh, these are the problems we want to solve. We want to be able to reduce maternal mortality indices by ensuring that our pregnant women attend antenatal clinic more. You see, when we look at it like that, we're going to be able to see, okay, so what technology that is affordable and available where the pregnant women are can be deployed to solve that problem. Or we can sit down and say, oh, there's this particular technology that can be deployed in a rural place, requires a satellite, and then if you have a satellite connected to that technology, you'll be able to attend. And then we started ECOMSAT-1. And then one day the satellite disappeared from space. And we're back to zero. So those are the things we need to start looking at. Then the other part of that is that you can't look at, like Mrs. Tomilaya was mentioning, you can't look at one part or one stakeholder group and say, oh, these are the people behind telemedicine. It has to be an all-encompassing goal. I talked about the supply chain. You need to bring all stakeholders on board. So it's easy to say, oh, Federal Ministry of Health is behind health. So they should drive it, particularly if you want to look from the perspective of health. But then you have the Federal Ministry of Communications and Digital Economy that have an overarching role when you talk about technology. Then there are other, there's the Health Records Officers Regulatory Board that talks about digital health. That talks about health records themselves, how training is being done. If they are not trained, then you are not going to achieve anything, whatever it is that we choose to implement. So and then you have the telcos. So, for example, talking about mHealth, there was a time that if you decide to choose to implement a particular solution, the telcos believe that they are there for business. They are not a social venture. And they must be able to generate revenue and returns on their investment. So you want to run, for example, say there's this text it that you use to engage pregnant women in the rural areas to inform them about what health issues they should expect at different level of their pregnancies, or you want to use to remind tuberculosis patients to take their medications. I'm going to be talking about SMSs. So who pays for the SMSs? Or you are talking about short codes. The telcos have their charges for SMSs or percentage they take. If if you're using short codes. But what they do for banks who generate revenue cannot be the same thing they will do for health. So it's not enough to say, oh, you have to work with all the stakeholders. We have to put everybody in the same room on the same round table and lay down the objectives. And everybody comes with, from their perspectives, what objectives they want to, and then you iron things out. You stay on the same page, you sort it out. That way you're able to solve more problems than one person going the way and trying to push an agenda that is not, that does not cut across board and is not everybody's agenda. So that's the place of, bringing all stakeholders together and then being able to see the different perspectives and then setting out what are your health objectives and addressing the issues from that perspective. I hope I've not lost track of the question you asked, and I hope that I've been able to address, if not all of it, at least part of it.
Okay, thank you very much. I think it gave you opportunity to say more to the topic. I quite understand what you're driving at. The point is where to start from. It's not necessarily the technology. It's what our needs are, and then having to develop technology that suits those needs rather than impose technology from outside. That's quite clear. But I wanted to know whether we even have the technological base that can respond to already known needs. But that's fine. I think you have made the point. I'm not sure I can see any question now, or we can't see nothing here to. Somebody remarked that here more. I like the term gospel. That was the term used by Miss Akinsiku when she spoke moments ago, talking about promoting e-health. We need more e-health evangelists, EMOA says, to push the importance and need for e-health to enable us have universal health coverage. Very correct. That makes plenty of sense. The louder we are about it, the more stakeholders will hopefully give it attention. Right, so that said, I would want to bring this session to a close. And that actually brings some closure to today's session. We appreciate every person that has been on. Okay, I think we should first of all declare or close this particular session before we round up for the day. We want to say a big thank you to Dr. Adeolu Arobundade, Medical Director, Lagos State Accident and Emergency Center, President, Society for Telemedicine and E-Health in Nigeria. We appreciate you so very much. Thank you for all the trouble that it took for you to even get on to us. At the time, we were not communicating effectively with you, but importantly and very, very encouragingly, you were even actively engaged in trying to see that we do not miss out on the opportunities we could benefit from you. Thank you for your humility. Thank you for your availability. Thank you for being so resourceful. Thank you for sharing with us your personal experiences from a very practical point of view. I'm happy you've been a part of the history of e-health and telemedicine in Nigeria. You've been actively engaged also at federal capital, at Lagos state level. We pray and hope that all of this will come out to fruition and bring about universal coverage, health service coverage in Nigeria. Thank you very much. We also want to thank our very dear nurse who has moved into different fields. From being a registered nurse, she became a degree holder in nursing and then later a specialist in public health. From there, went into health informatics. and now it's becoming the main backbone of your everyday practice of nursing in the UK. We appreciate you very much for sharing your experiences with us. And our wish for you is to continue to make progress, to advance more and more, and be a good Nigerian where you are and showcase your disposition to make life better for humankind. We also wish you the very best in your career and in all that you do. We thank all the participants who have been online since this symposium, this second symposium started. Thank you very much also. Thank you for your comments. Thank you for holding on and being with us. At this point, I want to say we have brought that symposium to a close. Now we talk about today. Today, the 16th day of March 2021. Thank you very much for all those who have participated in today's activities. Thank you for holding on. Thank you for making the program worth the while. We appreciate you for everything that you have done. Thank you for populating the place. Thank you for those of you who are the viewing centers, whom we may not be seeing from our control room. You may not be electronically visible, but we know you're there. We are seeing your pictures. We appreciate you for being a part of this. And we hope that the lessons learned today will be put into practice immediately. Once again, thank you. Now, talking about tomorrow, tomorrow is day 3. And we hope that you all have a copy of the program for those who have registered. And this is, again, another opportunity to appeal to everyone here. Please register. Please also get your friends, your neighbors, your colleagues, your professional colleagues, ICT people, engineers, health workers, and so on and so forth, and students to register for this conference. That way, they get free access to participate. That means that they're able to log in, they'll have login details, they'll have access to readings, daily readings. They'll be able to engage in discussions, they'll be able to put up questions, answer questions, chat, and so on. And it's all free of charge. The only difference is for those who are paying for the conference. If you pay for the conference, in addition to all of this we have talked about, you're going to get a free copy of the e-brochure for this conference. You're also going to get the book of abstracts, electronic book of abstracts free of charge. And we are going to take our abstracts on Thursday. In addition, you're going to have access to the full recording of this conference. So once again, please mobilize all to participate, to go on and register. And if you have registered and you don't have the entry credentials yet, please feel free to call any of us whose numbers you have seen in our flyers, in our messages, or anywhere, including mine. Go to the social media outlets, on Instagram, Twitter, LinkedIn, and so on and so forth. You will see MEHID-Africa 2021. Call any number there or send a message, and you'll be helped to log in as soon as you register. Thank you very much indeed. So we now have the national anthem to close for the day. National anthem, please.
Oh God of creation, direct our noble cause and guide our leaders right. Help our youths the truth to know. In love and honesty to grow and live in just and true. Great love, heights attain to build a nation where peace and justice shall reign.
Okay. Did you log me out? All right, thank you very much. We appreciate you and we look forward to a greater day tomorrow.